Good evening, everyone. So I'm Dr. Arun. So I'm currently working in UK as a senior clinical fellow. So I've done my European diploma in intensive care with Farz Academy last year, and I passed successfully. And my area of interest is point of care ultrasound, and I'm a Fusic Heart and Lung mentor, which is a training program accreditation in the echocardiography and lung ultrasound. So congratulations everyone for joining this session and clearing EDIC part 1, preparing for part 2. You are in really safe hands with Farz Academy. It's one of the most effective courses available online currently for part 2. The objectives for this session, I'll try to orient you towards like EDIC part 2 exam, more towards the CCS this session. So this session is going to be like a simulation of the actual exam. So I've prepared the slides just like the actual exam with some discussion like related to that. And this is a best place for you to practice answering and will really help you pass the exam. So be involved, try and answer. And yeah, I will try and modify your answers if there is any requirement which is need to be adapted to the exam standards. So let's keep it interactive, and the more you talk, more you will get benefited. So I encourage you to strongly get yourself involved and take maximum out of this. Please keep your videos on if possible, so we can interact each other, and I can see some of your names, so that's fine. And yeah, if possible, we can encourage everyone to participate and answer. That will make it more interactive and engaging for everyone, and it will be helpful for you as well for the exam. And feel free to interrupt and clear your doubts as and when needed. There is some echo going on, so I'll try to address that first. Fine. So let's start with the exam case. A 45-year-old man with a history of heavy alcohol use presents to the ED with a 24-hour history of severe, constant epigastric pain radiating to his back, associated with nausea and vomiting. So on examination, he is tachycardic, heart rate 110, hypotensive, and has epigastric tenderness. His abdomen is distended but soft. Initial bloods you have done, amylase is 1500, lipase is 2200, counts elevated, hematocrit is 48, creatinine is 1.2, lactate is 3.5. What's the most likely diagnosis, and what are your differentials? Why don't we start? I hope everyone can answer. You are not busy, or if there is any problem, please send me a message so we can see in the chat. I won't asking you questions. Anyone open to answer?
Okay, let me try. John. Yeah. Okay, the most likely diagnosis in this case is an acute pancreatitis.
Excellent.
Yeah, the differentials will include all the causes of pain in the epigastric and chest area, like acute MI, acute peptic ulcer disease, aortic dissection.
Yeah, very good.
Yeah. Acute pericarditis. It's also a possibility.
Yeah, these are the common things, right? But you got it really correct. And here we have more clear, like the lipase is elevated, so we are pretty sure it's pancreatitis. So there's no problem with that. So how are you going to manage it?
Okay, my first step in the management of this case is I apply ABC of resuscitation. In this case, I'm sure from the history, the airway is patent, and possibly this patient is breathing well. So the most important need now, because of there's hypotension, the blood pressure is about 90, borderline hypotension. So fluid resuscitation will be uppermost in the management, and at this point in time, resuscitate with rain gas lactate, and then analgesia. We will also give him analgesia, preferably opioids like maybe fentanyl or fentanyl to relieve pain. That would be my initial first step: fluid resuscitation and analgesia.
Yeah, fair enough. So anyone else have anything to add? I just wanted to discuss in these topics how we are going to manage this patient. Let's discuss each one in detail. Like you said, I like to answer of ABC, but more refined answer compared for EDIC exam, I would say like A to E assessment, a rapid A to E assessment, and address each problem then and there, then proceed to the next stage. Yeah. So that's how I would put it. That looks slightly better rather than simply saying ABC. And you touched upon analgesia. Anyone, I mean, whoever is free and confident can open up and answer. Even if you say anything wrong, that's absolutely fine. We are just here to share knowledge and learn from each other. So feel free to unmute yourself and chip in. So with regards to analgesia, let's discuss analgesia. So what are the problems with opioids? You mentioned fentanyl. So what is the problem you face with fentanyl or opioids in general in pain management in related to these patients?
Okay, one of the most important concerns would be that it may cause because they cause spasm of the sphincter of OD, and it might it might worsen. Of course, it may cause a bloating of the intestines, and we have bloating. That's a gastrointestinal motility may be impaired as a result of the opioids.
Exactly, ileus.
Yeah.
Already, because of pancreatitis, they are going to have some ileus, and this is going to worsen the problem. So it's difficult to choose an analgesia in the outpatient setting, like as an inpatient, even outside critical care area, when you are like where you cannot use the other options like ketamine and dexmet safely. But these are the other options nowadays coming up in critical care, alternative to opioids. That's the thing about analgesia. And anyone else want to comment on nutrition? How are you going to manage the nutrition?
Start early enteral nutrition.
Mm-hmm.
We like to give nutrition through nasogastric tube. First, encourage the patient to take orally. If not possible, then I will put a Riles tube and encourage nasogastric nutrition. And if still patient is not able to accept, then I will put a nasojejunal tube. Total parenteral nutrition is reserved for patients having GI motility issues or peristalsis. And so we basically aim for early enteral nutrition in these patients.
Yeah, you're absolutely correct. I think the dogma of the previous years, previous decades was like giving pancreatic rest and not feed the patient, but we are moving away from there. And if you read this American Gastroenterology update, which came out in like 5 years ago, they even talk about doing like gastrostomies in patients who are not able to swallow and not tolerating NG or NJ, even before considering TPN, which I found really interesting. Yeah, but you are absolutely correct in whatever you said. Then moving on, fluid management. Anyone else want to chip in?
Sir, can I answer?
Yeah, absolutely.
Regarding fluid management,
initially, if the patient is hypovolemic or if there is evidence of shock, we can give a fluid bolus of 10 ml per kg. And after that, we will give a maintenance of 1.5 ml per kg per hour for the initial 24 to 48 hours. Too aggressive resuscitation is not advocated now.
And why is that?
Because
Waterfall trial.
Yes, waterfall trial, it has shown to increase fluid overload complications like pulmonary edema, ARDS.
Yeah. And more worrisome is intra-abdominal hypertension as well.
Yeah, intra-abdominal hypertension here.